be talking on diabetic macular edema, and I've been allotted 12 minutes, so I will just plunge headlong into the topic. So I'm not going to talk about the incidents and all that because it was so beautifully covered by Dr. Vinod in his previous talk. So let's go on to the investigations in diabetic macular edema. Gold standard and the law and the investigation which has been there for dog's ears is fundus fluorescein angiography. And it can beautifully image these new vessels as seen here with the adjacent capillary non-perfusion areas and a baby new vessel here. And in a clinically significant macular edema, the diffuse leakage can be made out as well as the focal points of leakage from the microaneurysms. So FFA has been there, and it has actually, helped us in a lot of ways, retinologists. And for instance, this patient has 3/60 vision, but you can see that there's not much of macular edema except perhaps a waxy pallor here. And not a very brisk foveal reflex. But, when we do the fluorescein angiography, it reveals a widespread macular ischemia. And this patient had diabetic nephropathy as well. In fact, macular ischemia has been said to be a marker of diabetic nephropathy. And fundus fluorescein angiography can beautifully pick up this condition. But of course, there are several shortcomings of fluorescein angiography in DME. All microaneurysms cannot be delineated because of extensive leakage. The deeper capillary plexus, and more interest nowadays is on the DCP. That is not possible. And also the delineation of the FAZ size is also confounded with the leakage, so that's also not possible. And we cannot make out any serous macular detachment. So which brings us to OCT, which has optical coherence tomography, which has been a game changer in the way we manage diabetic macular edema. And we all know what OCT does and what is the principles. I'm not getting into that. For instance, if you just look at diabetic macular edema, these two pictures beautifully illustrate how OCT helps the retinologist to decide what to do. This is a case of diabetic macular edema with intramacular traction. So no matter how many intravitreal injections you're going to give, this patient is not going to become okay. This patient needs a vitrectomy. Whereas this is a patient with a cystoid macular edema and a taut posterior hyaloid and epiretinal membrane. So this patient can be given a course of anti-VEGF injections or steroids and managed conservatively before deciding on vitrectomy in unresponsive cases. So in diabetic macular edema, OCT helps us to decide whether there's an edema or whether there's an ischemia, and also helps us in the wide field OCTAs especially, we can get an index about the extent of peripheral capillary non-perfusion as well. So initially, we used to classify diabetic macular edema as clinically significant macular edema and non-CSME. But after OCT has come, we classify it actually as center involving and non-center involving diabetic macular edema. And based on OCT, the morphology and according to the morphology, DME can be classified as spongy swelling, cystoid swelling, serous detachment, and taut posterior hyaloid membrane. For example, this is just a widespread sponge-like swelling, whereas here you have cysts with these walls or septae. So this is a cystoid macular edema. And this is a subretinal fluid. We can see that there is a fluid between retinal pigment epithelium and the photoreceptors. The subretinal fluid basically indicates that the retinal pigment epithelial pump is sick. And as you can see, the RP layer is actually looking very thinned out. So, and it also indicates chronicity. And of course, it's got a guarded visual prognosis. And whenever OCT picks up this extensive CME as well as subretinal fluid, actually, it's not at all a good idea to do focal laser in these patients. And it's also important that these patients, we work in conjunction with an intensivist to rule out uncontrolled hypertension, nephropathy, anemia, etc. And it's also said that subretinal fluid has a protective role based on several studies, and it can respond well to intravitreal anti-VEGF therapy. And OCT also gives us this map of the retinal thickness, and we can serially, when we measure these retinal thickness maps and see these retinal thickness maps serially, we can get an idea about how the thickness of retina is increasing or decreasing. Apart from that, a lot of interest is nowadays on the various OCT biomarkers, the prognostic markers in diabetic macular edema. I have listed all of them here. And most important would be hyperreflective dots, especially in the OCT. There is an option wherein you can do the white on dark flip, and there you make out these hyperreflective dots as black dots here, either intraretinally or even in the subretinal space or within the cystoid spaces. You can make out these hyperreflective dots, and it is usually signs of inflammation and dead microglia. And as a beginner, one might not be able to distinguish whether whether it's a hard exudate or a hyperreflective dot. The hard exudates are thicker and usually associated with shadowing, whereas the hyperreflective dots are usually smaller. And they can be present intraretinally, and usually there is a poor response to anti-VEGF injections. And because of the inflammatory pathogenesis, intraocular steroids are probably more useful. In subretinal hyperreflective dots, one must rule out hypertension and diabetic nephropathy. And a good systemic control is very, very important in such cases. The another important terminology in diabetic macular edema is DRIL, which is the horizontal extent in microns, wherein you cannot distinguish the boundaries between the inner retinal layers. For instance, this is a patient in which you have, as a beginner, if you just see the OCT, if you see these two white lines and this gray area, so this signifies that there is no DRIL and the inner neurosensory retina is actually intact. This is the inner plexiform layer and this is the outer plexiform layer. Whereas here, if you see, here there are the two white lines and the gray line, whereas here the demarcation is not very clear. So this patient has DRIL in this eye. And DRIL is a poor prognostic factor, and also several OCT biomarkers like loss of parallelism and an epiretinal membrane. This is a pre-surgery, and after surgery, the patient is actually doing quite well. This is a post-surgery picture. And also, a lot of interest is now garnered on the outer retinal integrity and health in diabetic macular edema. Reduction in ellipsoid zone reflectivity with ELM loss are all said to be poor prognostic factors. And also presence of outer retinal tubulations, which sometimes we talk about ORTs in CNBMs. We also talk about ORTs in diabetic macular edema. They are hyporeflective tubular structures surrounded by hyperreflective ring. They are not subretinal fluid. A beginner might misunderstand, misdiagnose it as intraretinal or subretinal fluid. This is basically outer retinal tubulation, and it's again a sign of chronicity. And diabetic choroidopathy, as we evolve in our understanding of medical retinal disorders, choroid is a very, very important, got a very important role to play, not only in CSR and CNBM and pachychoroid conditions, but also in diabetic macular edema. And then several studies have shown that choroidal vascular density and volume are reduced in more advanced stages of diabetic macular edema. Just quickly about OCTA, the OCT angiography is the next big thing. It can demonstrate all the diabetic retinopathy findings like microaneurysms, irmas, etc. It's rapid and non-invasive. Unlike an FFA, the only thing is we cannot make out a hot disk unlike an FFA. So there's no information on blood retinal barrier status, and you can't delineate all the microaneurysms actually, but more or less it does the job. For example, this is the superficial plexus, and the advantage of OCTA is we're able to get even the imaging of the deep capillary plexus. And nowadays, the deep and the middle capillary plexus, the pathogenesis, the pathology which is happening there is supposed to be more important in the evolution of diabetic macular edema. You can see the capillary non-perfusion areas as well as the microaneurysms and telangiectasias in the deep plexus in a case of diabetic macular edema. And we can also do angioanalytics in which we can measure the non-flow areas. As you can see, the FAZ and the non-flow areas can be measured. Interestingly, even in patients without diabetic retinopathy, the FAZ is said to be increased in size. And you can even quantify the non-flow area and then serially follow it up also as an index of ischemia. And we can and we do a wide field OCTA also, and as well as in an ordinary OCTA also, the FAZ size is increased. That's said to correlate with peripheral ischemia and diabetic retinopathy grading. Now, this is a very important study which actually highlighted the importance of the deep capillary plexus loss in OCTA as well as the disruption of the outer plexiform layer in a spectral domain OCT. For instance, this patient, the outer plexiform layer in the spectral domain OCT is relatively intact, and the deep capillary plexus is also, the FAZ is relatively intact. And this patient responded very well to anti-VEGF injection. These are from Lee's article. I would suggest all the ophthalmologists to kindly go through this article if time permits. And this is a patient who has extensive deep capillary plexus ischemia as well as disruption in the outer plexiform layer, and this patient did not respond well to anti-VEGF agents. So whenever patients have disruption in the outer plexiform layer and are not responding to anti-VEGF, it's better to switch to intravitreal steroids. And there are several reasons why the DCP loss translates to anti-VEGF unresponsiveness. And coming to the treatment of diabetic macular edema, so why do we treat diabetic macular edema? Because without treatment, 50% of eyes will lose greater than or equal to 2 lines of vision within 2 years of diagnosis. And we have several tools in our armamentarium, the gold standard laser, as well as pharmacotherapy, anti-VEGF agents, steroids, combination therapy, surgery, and of course, a holistic approach. So the treatment of visual impairment due to diabetic macular edema has basically evolved over time from 1985 to 2014 till date. We started with laser photocoagulation, anti-VEGF injections, ranibizumab, then we went to steroids, fluorescein and acetonide, dexamethasone, and aflibercept, an anti-VEGF agent. And now we are looking at the newer kids anti-VEGF agents on the block. So coming to pharmacotherapy in diabetic macular edema, if we see the pathophysiology of DME, both increased VEGF as well as inflammation, both are chronic subclinical inflammation, both play a part in the diabetic macular edema. Hence the rationale of use of anti-VEGF agents as well as intravitreal steroids. So I've told you the rationale of anti-VEGF agents, and we have several agents in DME, and definitely all the studies have time and again proved that anti-VEGF agents, when compared to laser, have better best corrected visual acuity improvements. We have so many studies, and after the advent of anti-VEGF agents, there's a paradigm shift in the way we manage diabetic macular edema. We are seeing better central retinal thickness reductions. And supposing there is a lot of exudates in a patient, we do excessive laser. Sometimes we see the precipitation of exudates and subfoveal exudates and all that. That is not seen with anti-VEGF agents. And there is also a paradigm shift. Initially, in the laser era, we used to tell the patient that you need to undergo laser to preserve your existing vision. Now, for the first time, we are telling the patient that your vision can actually be improved. And initially, we used to do lasers with adjunctive anti-VEGFs, but nowadays we give anti-VEGFs with adjunctive lasers for diabetic macular edema. And of course, it's got several pitfalls because the anti-VEGF agents may reach the circulation, especially with bigger agents with a greater Fc component like Avastin, Bevacizumab. So probably the VEGF is blocked, and VEGF, all of us know how important VEGF is to us, especially in a diabetic patient, for instance. A VEGF is important for the development of myocardial collaterals. So anti-VEGF agents, if you inject, especially the bigger ones, which circulate in the body for a long time. For example, Avastin circulates for more than 20 days. So that can put the patient at risk for a silent heart attack. And also it can critically cause vasoconstriction of macular capillary bed. And there can be other eye effects. For instance, if one eye has tractional retinal detachment, then the other eye has diabetic macular edema, I will not inject an anti-VEGF agent in the eye with diabetic macular edema for fear of worsening of the tractional macular detachment in the other eye. And of course, Avastin is non-FDA approved and all that, and probably a higher incidence of systemic adverse events and several pitfalls. And there are indications in which anti-VEGF agents do fail. For example, this is a patient which we continue to inject and do well and ultimately had to undergo vitrectomy. And anti-VEGF agents alone are insufficient in over 1/3 of patients, which supports a role for steroids in the management of diabetic macular edema. In fact, DRCR Protocol T, a seminal trial, which is like the CAT trial for AMD, we have the DRCR Protocol T for DME. And see that roughly 34, 42, and 64% of patients who actually underwent anti-VEGF injections, despite receiving 10 injections, they continue to have a high macular thickness, and 1/3 of patients showed persistent edema over the first year, which tells us that there is a rationale for use of intravitreal steroids in DME because they decrease the paracellular permeability and increase the tight junctions, and they have anti-inflammatory as well as some amount of anti-VEGF action. And they have all these anatomical, physiological, and they act against all these biochemical factors, and they reduce the inflammation. And we have several steroids, starting with Tricot to Ozurdex to Iluvien. And this is from our review article on triamcinolone acetonide for diabetic macular edema in the Indian Journal of Ophthalmology. And this is a patient responded very well to Tricot injection. It's called poor man's anti-VEGF, and Dexamethasone implant for DME also works well. This was a patient who was unresponsive to laser, multiple anti-VEGF injections, did very well with Ozurdex, and several trials also talk about the efficacy of Ozurdex in diabetic macular edema. In fact, the rapid regression of hard exudates from the foveal center was suggested by Ozurdex Trial. Compared Ozurdex with Bevacizumab. And this patient, it's another example from May 2011, June 2011, several injections of anti-VEGF agents and focal, but finally with Ozurdex, this patient started stabilizing and did very well. And Iluvien is another implant, a steroid implant, which lasts for 2 to 3 years with a 25-gauge injectable implant. And this actually shows one such patient who's received Iluvien with, very good control of the diabetic macular edema. So the important facts are anti-VEGFs are basically intermittent therapy, and the diabetic macular edema is basically a chronic process. So there can be a suboptimal response because of fluctuating drug levels in the vitreous reservoir. So probably a long-acting steroid may also be an effective alternative. Of course, it has got several pitfalls like glaucoma, cataract, and there is no wow effect. And another important role for intravitreal steroid is in a patient with diabetic macular edema and cataract, because all of us know that once the patient with active diabetic macular edema undergoes cataract surgery, the diabetic macular edema can actually increase because of the Irvin gas component. So if we give an intravitreal steroid followed 10 days later by the cataract surgery, then the results are very good. This was shown by a PGI study also. And laser therapy for diabetic macular edema, I'll briefly touch. It has been the gold standard since 1985 with a modified ETDRS protocol, which actually said basically laser everything, all the lesions which are seen on angiography. But it's no longer true. We just do nowadays a focal laser alone. We place a gentle 100 micron burn over a microaneurysm once or twice till the microaneurysm either darkens or whitens. And I personally do not like this grid or the modified grid because it creates a sieve-like scotoma and you have a very unhappy patient. So if there are well-delineated focal microaneurysms, then best is to do a focal laser. But if there are any cystoid spaces or subretinal fluid, then the gold standard is an anti-VEGF injection, as well as in unresponsive in certain other cases, we can try intravitreal steroids. This is one such patient who has undergone a modified ETDRS protocol and a grid laser for CSME. I'm sure this patient, edema would have gone, but the patient is not a happy patient at all. So ETDRS actually said focal laser reduced the risk of moderate vision loss in CSME by 50%, but visual acuity improvement was observed in less than 3% of cases. So I personally reserve laser only when there are well-delineated microaneurysms. And these are the several side effects of conventional laser. And the DRCR Protocol T also shows appalling, results of laser when compared to anti-VEGF injections. And we have several prospects. We have the most interesting is the subthreshold micropulse LO laser, which we've started employing with very good results. And you can see that the laser marks actually will not be visible, but you can see beautiful resolution of the edema. And the LO laser especially provides peak absorption of oxyhemoglobin, negligible xanthophyll absorption, excellent penetration through cataracts with lesser pain and lower intraocular light scattering and lower energy. So it's a very good laser to use for diabetic macular edema. And we have several refinements like wide field angiography guided peripheral PRP, which will reduce the acute VEGF burden and therefore reduce the macular edema over time, navilas, so on and so forth. And also we have the medical retinal field is actually pretty interesting and exciting. We have several over-the-horizon drugs available in the pipeline, in the market, which will actually broaden the success rate of the way we treat diabetic macular edema. So thank you very much for your patient hearing.